Well, good afternoon, everybody, and thank you for joining today's webinar, Improving Stroke Care, the Impact of COVID-19, Present and Future. My name is Derek Munn, and I'm the Director of Policy and Public Affairs here at the Royal College. I'll be chairing today, and the webinar will last an hour. I'm delighted to introduce our speakers for today. First of all, Professor Pam Enderby, the Emeritus Professor at the University of Sheffield. Secondly, Sue Pownall, who is Head of SLT and Clinical Lead in Dysphagia at Sheffield Teaching Hospitals. And I'm particularly pleased to welcome our guest today, Juliet Bouverie, who is the CEO of the Stroke Association. Just by way of housekeeping, I'm sure many of you will be getting used to this during lockdown, but you can send in chat messages at any time by using the chat button. If you've got a question you'd like the panelists to answer, please do use the Q&A button. We will get through as many of the questions as we can, but any that we can't answer live, we'll undertake to put an answer online after. The event is being recorded. You'll see the link there to recordings that we've done in the past. There'll be a short survey immediately after the event, so it would be really helpful if you could fill that in. And my colleague Claire and my colleague Rachel are available to assist you with any technical issues that you've got during the webinar. The aims and objectives for today. We hope that an hour from now, you'll have an understanding of the patient experience for people with aphasia, knowing how services are adapting in the light of COVID-19, how to continue to meet those existing stroke targets in the new normal. Here's around community provision of therapy, including different assessments and remote provision of therapy, and around working in multidisciplinary teams to deliver patient care pathways. And so, I'm pleased to hand over, first of all, to Juliet Bouverie.
Thank you very much, Derek, and good afternoon, everybody. Thank you very much for joining this webinar. And we're going to start this afternoon just hearing what the lived experience is of stroke survivors and their carers. And I'm going to share with you some data that the Stroke Association has gathered on people's experiences pre-COVID, but also the results of a large survey that we've recently done with people affected by stroke. So next slide, please. So what were the unmet needs of stroke survivors before COVID-19? Well, we know that when stroke survivors are discharged from hospital and they go home, many of them report feeling abandoned. And we consistently hear stories of people feeling that they've been they've jumped off a cliff and a lot of that kind of wraparound support that was available in hospital falls away, and that they feel that they're left to fend for themselves. We know that there is insufficient follow-up for stroke survivors once they're back in the community. Not enough people are accessing the fully comprehensive early supported discharge service. And then for many, the support then falls away after 6 weeks. And we know from the SNAP data that only 1/3 of patients are actually being followed up at 6 months, and even fewer annually thereafter. And we did a major piece of market research last year and published a series of reports about the lived experience of stroke. And in that survey, 1 in 4 stroke survivors told us they just didn't receive enough support when they needed it. And 1/3 of those stroke survivors felt that the support was restricted to focusing on their medical conditions and didn't really focus on them as a person or an individual. Next slide, please. We've also done some specific market research with people with aphasia. And what we did was we did a literature search, we did in-depth interviews with 12 stroke survivors with aphasia. And then in 2018, we did a large piece of market research where we consulted with over 100 people with aphasia across the UK. And we published that report in 2019. And I think it's fair to say that the findings are probably familiar to you, but they are really stark. So stroke survivors with aphasia told us that they really did feel misunderstood, not just by those close to them, but also the wider community. They felt even more socially isolated and lonely than stroke survivors who are able to communicate. And that isolation had a huge impact on their mental health and well-being. And we were overwhelmed with really sad stories about the anxiety and depression that people with aphasia experience, and the really sudden and dramatic loss in confidence associated with their stroke. And we know from the SNAP data that there is a shortage across the UK in speech and language therapy provision generally, but particularly problems at weekends. Next slide, please. So how has the pandemic impacted stroke survivors in the UK? Well, we have just analysed the results of a beneficiary survey that closed a couple of weeks ago, where we had over 2,000 responses to the survey. About 80% of the respondents were stroke survivors, about 20% were carers, and about 5% of people had had their stroke since the middle of March, since the coronavirus pandemic really kicked off. And what we heard is that stroke survivors continue to tell us they're feeling abandoned when they leave hospital, that they're not getting access to the dose and intensity of rehabilitation that they want, and it's certainly not in line with the national standards, and that because a lot of the primary care services are not open and there for them, they feel that their care is not joined up. Interestingly, virtual methods of therapy delivery have affected stroke survivors differently, and I'm going to come on to some quotes where you will actually find some people being very positive about virtual therapies, others less so. But what really came out starkly was that stroke survivors are feeling significantly more isolated and lonely, but also very high anxiety and depression levels. I think we cannot underestimate the emotional and psychological impacts that such a sudden brain attack has on people with stroke. And obviously with coronavirus, those feelings of isolation and anxiety have been exacerbated. And we're also hearing from family members and carers that they're taking on even more caring responsibilities with the lack of availability of some of those therapy services, and are getting increasingly exhausted. So just to bring that to life with a few quotes, a couple of other just key stats before I move on to the quotes. So we do know appointments have been cancelled or delayed. Some of them have been cancelled by the system. Some of them have been delayed by stroke survivors or family members themselves because they're frightened about catching the coronavirus. People have adjusted to new methods of therapy delivery, and some, as I said earlier, have been really quite positive about phone and video contact. But we do know that stroke survivors who have severe aphasia and those with severe cognitive challenges really do struggle with phone and digital, both getting online but also using the technology effectively. And we have evidence of increasing digital exclusion because of these new technologies. So next slide. So here are some quotes. So some people are really enjoying Zoom and WhatsApp. Others saying that because they can't physically see people and they're not able to lip read and enjoy the benefit of kind of cues and body language, that they're finding it harder to engage, and that video calls for people with aphasia are more challenging. Next slide, please. Again, more evidence that people are struggling to participate in Skype calls. The second quote is a really shocking one, isn't it? You know, no speech therapy for 5 weeks, limited speech therapy whilst in hospital. That person's really concerned about the impact that has on her recovery and well-being. And then next slide, please. But some really nice quotes and encouraging quotes on the care and compassion that speech and language therapists are providing, and actually how people are actually really rather enjoying doing their speech and language therapy online. And you know how nice it is to have that kind of contact with people, to have a bit of a laugh. And I'm actually volunteering for one of the Stroke Association's new services called Here For You. And some of you may be horrified, but I'm actually using Tactus online. I'm not a trained speech and language therapist, but the person that I'm supporting has quite severe aphasia, but it's remarkable in 12 weeks how her speech and word recall is improving just because of the practice that I'm providing her with. So I'm now going to hand over to Sue, who's going to talk to you about the impact on services.
Thank you, Juliet. I'm going to talk about service issues arising in light of COVID-19. Next slide, please. And just to start with some figures, NHS England did an internal analysis during the initial surge period, and their information suggests that there was a 25% reduction in stroke admission during that initial surge period. We also know as well that the BAME community is disproportionately affected by COVID-19, and the stroke incidence is higher in Black and Afro-Caribbean individuals because they're at risk of developing high blood pressure, which can then lead on to developing stroke. So one of the things we need to think about is to look at the populations on our caseloads, and if there's a gap in those particular communities, we need to think about how we're going to address that proactively. To think, are there barriers to accessing our services? Is there a lack of awareness of the value that speech and language therapy can bring? Or is there a lack of understanding of the speech and language therapy role and that we can have a positive impact on outcomes? So we need to think about how we get those messages across to those community groups. Secondly, we know that patients have been presenting later to hospitals. And anecdotally, that's sometimes because patients are fearful of coming to hospital because of coronavirus, or that they're not wanting to put an extra burden onto the NHS. So as people are presenting later, there is some suggestion that some people have actually missed the thrombolysis window. TIA patients and stroke mimics have not been coming into hospital in the early days. And there is also a suggestion that we may start to see some more severe strokes appearing because the TIA, people who have had a TIA then go on to have a full-blown stroke. So to address that, many services have started to move to a virtual model to avoid patients having to attend hospital, particularly for those who've had a TIA. Cohorting patients has also been an issue, and this has been around bed management in particular. We know COVID positive patients are being cared for on COVID specific wards, and that's resulted in some patients being cared for by non-stroke specialist teams. And that's resulted in some people missing the therapy interventions that would usually be in place. However, to address that again, some services have started to look at the stroke teams doing in-reach work into those cohort wards. Over the period, there's been less intensive community services. And this has been for a number of reasons. In some places, it's because there's been redeployment of some of the stroke team. And this appears to be especially for speech and language therapy assistants. And they're often the ones that are carrying out the more intensive therapy programs. Or there's been less intensive services available as people try to reduce the number of visits that healthcare professionals are putting into people's homes. Also, a great number of people individuals who have had a stroke are in the shielding groups and haven't wanted a number of different therapists to be accessing their homes. We also need to remember as well people in care homes and the restricted access that we've had to care homes. And there is a view that people with suspected stroke have not always received appropriate assessments and are now not receiving the appropriate therapy. PPE has been a barrier. It's been a barrier both to assessment and to therapy. We know that masks hinder communication, and some patients, when they meet somebody who's in full PPE, are finding this quite distressing. But we also have to remember with PPE, the extra time that it takes both to don and doff the PPE kit, and also if you're seeing people in the therapy room, the extra cleaning that needs to take place. So if you think about the therapy resource that's available in perhaps an 8-hour working day, when you take into account the effects of PPE, there's actually less available resource to work with individual patients. Next slide, please. So since the pandemic, since March, there's been many changes in the way different stroke teams are working, and some of those will influence our future clinical practice. We're now moving into the restoration and recovery phases for our services, and we need to think about the things that we put in place very rapidly at the peak of the pandemic and start to evaluate those and adopt and amplify those interventions that we think have been effective. So one of those to think about is if we do go on to get a second surge, or we see more COVID positive patients being admitted to hospital, we need to get the balance between the respiratory needs and the stroke needs, and continue to think about whether as stroke specialists we are able to in-reach into those COVID cohorted wards. New discharge pathways and rehab models have emerged over this period, and we know that in many places when people present with a stroke in ED departments, that often if they're considered to be fit to sit, or in some places they term them the walking wounded, then they're not being admitted to HASUs or acute stroke units in the way they were before. They're being discharged straight home. And so the importance of early community intervention is becoming greater and greater. Promoting independence earlier is also key, and in many services, speech therapists are starting to introduce patients to telehealth and virtual platforms while they're still in the acute setting. That's so that people can get used to the interface of things like either FaceTime or WhatsApp or whatever platform they have on their own devices, so that people can start to use those earlier on in their stroke journey than they perhaps did before. Another issue has been around the national restriction on the no visitors policy to hospitals. And although that was lifted in June, it's still at the discretion of all the trusts to make a decision about whether visitors are allowed into the hospitals. And that has had a huge impact on lots of people who've had a stroke. So in many services, the speech therapists are starting to take on the role of more of the family communication, and they're establishing links very early on with families, again via remote means, and sometimes working with the individual themselves and their own device to make links with the families so that they can see the family, get support from the family early on, but also start to think about how that's going to work, providing remote therapy once somebody moves further down the pathway. Within the pathway working has also been affected in many areas, where speech therapists tended to work in different aspects of the pathway at different times during their working week. And some staff have been less able to do that because not only have we seen cohorting of patients, but we've seen cohorting of staff. So that's led to a need to actually ensure good communication is in place for effective transfer of care planning and rehab needs for patients as they move through the pathways. Next slide, please. So we've rapidly moved across all our stroke services to different ways of working. Remote working, as Juliet's mentioned, has been very useful for some people, but also very challenging for others. And we need to be ensuring that we do evaluate and find out going forwards, who does this work for and who doesn't it work for, and think about the new models for that so that we can maximise the potential for remote working, which we brought on very quickly in the NHS, far faster than anything we thought in the past we would be able to do. So we need to maximise its potential, but make sure we're using it with the right people. With care homes, as the restrictions in care homes start to be reduced, we need to start to think about the cohort of people there and make sure that we pick those people up in terms of providing more detailed assessment if they haven't had that already, and think about different therapy options going forward. Initial redeployment of staff is also starting to come to an end in many places, and staff are returning to their original posts within the stroke teams. But many staff have also extended the roles and are working in a more interdisciplinary way. And that's been very effective and has helped support reducing numbers of visits to individual people's homes, and has also helped to stop with the spread of infection. In terms of workforce generally, study leave is back on the agenda. It's very recently come back on the agenda, and so regional educational groups are starting to think about stroke education and adopting new approaches to do that, either via remote means again, or small groups such as Zoom, or looking at more interdisciplinary training. And one thing we mustn't forget is, going forward, the challenge we're going to have to services where, with the test and trace, with staff capacity, if we've got speech therapy or in small teams and the whole team has to go off for 14 days self-isolation, how that might impact on the care to the patients. So we need to be thinking about plans should that scenario occur. Next slide, please. So what will the new normal look like? We need to ensure there's a reduction or avoidance in admissions and transfers between hospitals in order to decrease the spread of transmission. We need to be thinking about the new ways of working and evaluating that, as we've said, delivering of services in different and innovative ways. Discharge from hospital is likely to happen quickly, but it needs to be done appropriately and as safely as possible to reduce the risk of spreading the virus. Early community provision is going to be a huge priority. And we need to think about the new interdisciplinary roles that have developed, and think about skill mix, and think about things like bringing within the workforce bilingual co-workers to support us with the BA-ME communities. And we need to think of those different, how those are going to work in the future, because we're likely to be in this scenario with COVID for a long time into the future. And so we need to embrace the new methods that are starting to appear. And as a final point, just the college guidance document, Restoring Services and Keeping Everyone Safe, is a link on the slide here and is a useful read for everybody in terms of developing the new normal. I'd now like to hand over to Pam, who's going to talk about rehabilitation.
Hello everybody, if I may, next slide please. I'm going to talk about rehabilitation in general, because there's a lot we can learn from our colleagues who take other roles in the care pathway. One of the things that's come up internationally is the impact of COVID on the general health of an individual. And it's very clear that exhaustion is one of the key issues. Now, that is always a problem after stroke anyway, but apparently it's exacerbated very much by COVID-related stroke. Of course, exhaustion is known to have an impact upon rehabilitation. And one of the key things is to allow people to have short but frequent sessions so they don't get overtired, and also perhaps a longer session would be of no benefit. So how can we do this? Well, if the person is exhausted, it's not giving them short little bits of speech therapy, but perhaps ensuring individuals can look at how they can spread their basic exercises across the day by using other individuals in the family, if that's possible, or in the care staff. We also know from studies internationally that many people who have been on ITU, on respirators particularly, have post-traumatic stress. We know that that affects learning and that people need a little more repetition and encouragement. Furthermore, COVID seems to have a particular impact on cognitive functions. So along with aphasia, that can be a complication. So we need to bear that in mind, perhaps thinking that more therapy for longer periods, I mean a longer period of timeline, over more months, might be required with COVID-related stroke. So there are likely to be an increased number of stroke patients as a sequelae to COVID, and we need to think of that complication when we go into rehabilitation. Next slide, please. We also know that there's an increased anxiety level of all patients and carers at this present time. They're anxious about whether they should make contact with different healthcare workers, etc. So we have to actually give them support and encouragement, but also be aware of these anxieties and handle them practically. What's particularly difficult for speech and language therapists is the reduced opportunities for communication with PPE. But it's made particularly difficult when somebody cannot use their hearing aid or their glasses. There are different types of amplifiers and different types of visual equipment that are easier to disinfect. So you may need to think of using those, and also encouraging members of staff of all professions to raise their voice and to try to use non-verbal communication as much as they can. Writing on whiteboards is always helpful and can assist people who've got hearing problems or need to have things written larger for their particular communication needs. We still, in many countries, have an uncertainty with regard to the path for rehabilitation. Many pathways have been clear and straightforward that are now being adapted. And there is a plethora of guidance with regard to how this might be the case and how we need to adapt it. The important thing is to be inventive, imaginative, and always thinking of putting the patient's needs first. And now I'm going to hand back to Sue, who's going to talk to us about dysphagia.
Thanks, Pam. So just a little bit about dysphagia. And to start with the SNAP targets. At the end of March, the SNAP team developed a core minimum data set, but it's been encouraging that even though they did that, around 80% of stroke teams have continued to keep the full data set. And one of the crucial targets within that is the early swallow screen. There is good evidence that an early screen results in improved outcomes. So we should be trying to adhere to that target. So the way some services are doing that, because patients aren't being admitted to hospital, which is often where the screen took place for that 4-hour target, people are starting to think about community screeners and training other people who are part of the community workforce to actually carry out the community screen. But within dysphagia services generally, there's tended to be less sharing of caseloads. And this has been in order to cohort staff to support the idea of reducing transmission of the virus. But the knock-on of this has been that we've not been able to provide daily input to patients as easily as we did before. Particularly if you're not sharing caseloads and many speech therapists work part-time, that's become an issue that some services are starting to need to look at. In terms of telehealth, we've talked a bit about telehealth, but there are college guidance on the college website that will talk to you about different telehealth options with dysphagia. Again, as we've already mentioned, this has been great for some people, less good for other people, but you also have to think about the risks and benefits of providing dysphagia assessments via telehealth. Remote consultations have been important, particularly by telephone with families when you need to offer support and guidance around things like how to thicken fluids if people are leaving hospitals on thickened fluids, or around dietary modifications. And lots of services have used the telephone consultations as much as they've used the telehealth and remote video consultations. There's been, over the pandemic, reduced access to both video fluoroscopy and fees. In video fluoroscopy, many services have managed to continue to run some video fluoroscopy clinics, but with less patients than they saw previously. And so that's been an issue in terms of building waiting lists for more instrumental assessment. Fees in many areas, well, in most areas, will have been ceased for the time being, again due to national guidance. But one of the other key things that has impacted on dysphagia services is the reduced intensity of therapy that's been available for things such as the AmpCare effective swallowing protocol or the McNeil therapies. All those that need daily input have been very difficult to provide when we've been having reduced intensity of staff and the ability to actually see people on a daily basis. Thank you. Next slide, please. Pam's going to move on to talk about the other aspects.
It's always hard to remember to unmute oneself. If you will bear with me, I'm going to use the word dysphagia and aphasia fairly interchangeably. We're going to start off by looking at screening. Very often a speech and language therapist is referred to by a member of staff when there is a concern about whether the person's got dysphagia or not. Of course, that's not quite so possible now, and we have to equip other staff members to do a screening test, and there are some screening tests that are available for non-speech and language therapists to use that we should be encouraging. This really makes us think that there are quite a few things that we should have been doing before COVID, and COVID's pushed us and encouraged us to adapt to some of the ways of working that would have perhaps been more appropriate to do some years ago. One of the other things is that the patient might have slurred speech, disordered speech sounds, and we need the team to recognise that dysarthria can indicate a swallowing problem in its own right. Now, sometimes a person with dysarthria might have screened quite well for the dysphagia. So why would one say that we need to keep that in mind? Well, mostly it's because dysarthric patients, their muscles tire quite easily. So on a screen, they might be swallowing quite well, but a little later when they become tired, so halfway through a meal, their muscles may not be coping so well, and they might begin to aspirate or to cough. So if there is a sound problem, you need to be aware of the possibility of dysphagia, but you need to alert the other members of the team of that difficulty. I am concerned that mental capacity during the pandemic has not been given the attention that it needs to be given, particularly as patients are being asked what their preference is with regard to being discharged, going to a care home, going to a relative, etc. Bear in mind, and encourage your colleagues to bear in mind, mental capacity and when support is required for making decisions. We know in all of the post-stroke rehabilitation pathway that early intervention is important. A patient needs to know why they're having difficulty in moving or in speaking. It's just come upon them suddenly. So we actually have to explain that to them, but also encourage all members of staff to encourage communication in whatever way, whether it is pointing, non-verbal communication, using charts, etc. Please get everybody to encourage. Family members sometimes don't like to encourage their stroke relative to communicate because they feel it might be making them make an effort. They need to be encouraged that that is not the case, that everybody needs to encourage everybody to communicate as much as they can. Using AAC is very important. And of course, I've already mentioned the importance of non-verbal communication. We have begun as a profession to look at telerehabilitation over the last few months more seriously than we have in previous years, despite the fact that we know that individuals quite like telerehabilitation if they're properly supported and have access to it. Don't forget that telerehabilitation is also to do with using the telephone. So the person doesn't always have to have a computer. That doesn't disadvantage them particularly. They can have the telephone as a mode of support, encouragement and therapy. Next slide, please. This aphasia software finder, many of you will probably find useful, as it allows you to say what type of software the individual would benefit from given the type of aphasia they have, and it gives some tips of how to use it and to personalize it for the individual. And now the next slide, please. I'd like to just draw your attention to the Stroke Association's website with regards to the coronavirus and stroke. I found that particularly useful, and it's hopefully you will find it the same. And the next slide, please. Dysphonia. I'm just going to spend a very short period of time on dysphonia. Many people following ventilation or tracheostomy will have trouble with breath support and will have the added problem of dysphonia, which we often do not see as associated with stroke. Don't forget to use voice amplifiers when that's required. And people in Italy have particularly found that if you encourage too much harsh voice exercise early on, it may have an abreaction and lead to nodules. So it might be best to take a more gentle approach with easy onset speech, graduated voice exercises, and periodic voice rest. If the dysphonia continues, referral to ENT is important. And the next slide, please. My last slide. I just want to draw your attention to the incredible amount of guidance that's coming out on rehabilitation and speech and language therapy from these organisations. May I draw your attention to the last one on the list? The UK has set up a community stroke hub team website that helps with particular sharing of information between community teams supporting stroke patients, and has resources on self-management, etc. There's a lot to look forward to and to be positive about. I think it's made us adopt and adapt and be more flexible than we have been before. And sometimes we need that little kick to change our practice and to be able to really think of what patients need. May I now hand over to my colleague Juliet, and hear about the Stroke Association's response.
Thank you very much, Pam. So I'm just going to briefly talk you through how the Stroke Association has responded over the last 4 months. And I just want to pay tribute actually to our staff and volunteers who have shown remarkable kind of agility and innovation over the last 4 months. But I also want to pay tribute to the whole stroke clinical community. I think you should feel so proud. I think the stroke services have been leading the way in terms of some of the innovations and adaptations that have been shown over the last 4 months. I know it's not easy for you guys, and that the coronavirus has impacted on your workloads enormously. And I can only imagine how tired you're getting, but I have to pay tribute to just how patient-centered and kind of innovative you've also been in your response. So next slide, please. So quite early on, I think from about the middle of March, we started to see quite a dramatic reduction in people presenting at emergency departments. You probably saw some of the data from the Royal College of Physicians that showed, compared to last year, there was a 50% decline at one point in people presenting at emergency departments, and that had a knock-on effect on stroke units. We saw a significant decline in stroke unit admissions, and we saw photos of some stroke units, not all, but some, almost half empty. Now, as the Stroke Association, we were really concerned. We know that stroke strikes every 5 minutes. And we were concerned that people were having strokes and not calling 999. So we responded very quickly. And in partnership with the British Association of Stroke Physicians, we launched a campaign to promote the message that stroke continues to be a medical emergency, and that if you're seeing the symptoms of stroke, it's imperative that you act fast and call 999. And I'm really pleased to say that that message has now been sustained by the NHS and governments across the UK. And you may have even picked up that it was mentioned in the Prime Minister's briefings a couple of times as a really key message for the NHS. Next slide, please. We've also adapted and developed our services because with effect from the middle of March, all of our stroke coordinators were working from home. So that meant that all face-to-face visits were replaced by phone and video assessments and consultations. And all of our stroke clubs and groups, again, have had to move online. And there's been incredible innovation. So we've launched 2 brand new services. The first is Here For You, and that's a volunteer-led service where we match trained volunteers with stroke survivors who are feeling particularly socially isolated. And the service is there just to provide companionship and support to people who are struggling with the emotional and practical impacts of stroke. And we've now recruited over 500 volunteers, and the feedback from the service so far is that it's really, really appreciated and making an enormous difference that people have someone to talk to. We've also launched Stroke Association Connect. It's a UK service. It's funded in partnership with NHS England in England. And it's a service for all newly discharged stroke survivors. And what we're doing is that when we get referrals from NHS teams, we are then following up immediately after discharge with an initial phone call to find out how people are, what information and support they would like. We're able to send them our booklets, we're able to signpost them to our and other services and provide them with that essential emotional and practical support to help them rebuild their lives after stroke. We're really pleased. As of earlier this week, we've now had 710 referrals and 57 NHS teams who've registered to refer people through to the service. If you haven't heard about it, please do go onto our website. That gives all the details of how to refer patients. And this is a service that is just as much there for you as it is for people affected by stroke, because this is a service that can help to alleviate some of the workload pressures that I know that you're all feeling. We're evaluating the service in real time with qualitative and quantitative feedback, and the feedback from beneficiaries so far is incredibly positive. We've also expanded capacity on our stroke helpline, again another UK service. Our stroke helpline is staffed by trained stroke experts. We've increased the amount of money that we have available for our financial hardship and life after stroke grants. Again, you can access those. And as Pam referred to earlier, we've created a whole new section on our website with really comprehensive pages about the evidence on the link between coronavirus and stroke. We've got resources on how to look after your mental health and emotional well-being. We've partnered with with later life training to promote videos and advice on how you can keep yourself physically active. There's some lovely videos on what you can do if you're chair bound or just able to stand, how you can keep yourself active. And again, all of these resources are in easy read materials suitable for people with aphasia. Next slide, please. And we've adapted our services. So just as an example of what we've been doing in Northern Ireland, we do have a speech and language therapy service across the whole of Northern Ireland. And we devised and delivered an innovative 6-week virtual aphasia communication plus program using Zoom. So the program included a one-to-one assessment with a speech and language therapist. And then it was a 6-week program with maximum 3 to 4 people, and then a review at the end of the program. And we evaluated it using the COAST rating scale, and it was supported by comments from users of the service. And the feedback has been so positive that we're now running a similar pilot with communication support staff across the whole of England. Next slide, please. We've also produced resources specifically for people with aphasia. We know that one of the problems that people with aphasia experience is actually not being able to get online in the first place. So we've produced a really comprehensive, really simple aphasia-friendly guide to how to get online, how to download some of the useful apps like WhatsApp, FaceTime, Zoom, and it's got really simple tips and advice, and it's going down very well, so please do use that. We've also produced equivalent resources for video calling. Next slide, please. So everything that I've spoken about is available on our website. Please do go onto it. There are some really useful resources for your patients. Here are the links to the 2 guides that I've spoken to for people with aphasia. And the next slide, please. And you can also find on our website more information about the Stroke Association Connect service, how you can refer people to that service and how you can be a registering team. More information about our Here For You volunteer telephone service. And again, please don't forget My Stroke Guide. It's a one-stop shop where stroke survivors and their carers can chat in a private space, share tips and advice, and there's some wonderful videos and resources that have been created by both people affected by stroke and healthcare professionals. So it really is a useful resource. And just finally, my next slide is just to talk to you about what the Stroke Association is going to do next. Well, we are going to continue to champion the importance of stroke remaining a key clinical priority for governments across the UK. As many of you will know, we ran a successful campaign to get stroke recognised as a new priority in the NHS long-term plan for England. But we know that plan is going to be refreshed, and so we're doing everything that we can to be sure that it continues to be a priority, but in particular to promote the importance of stroke rehabilitation. We know that stroke rehabilitation is not given the investment and funding that it needs, and we know that in particular speech and language therapy is underfunded, under-resourced. So we will be using the findings of our beneficiary survey to promote a really strong message about the importance of stroke rehabilitation, including speech and language therapy. I think we've also realised from both our insights, but also from what Pam and Sue have spoken about, that going forwards, we really do need to personalise our approaches to care. A one-size-fits-all model doesn't work. People have different needs, different expectations, different preferences, and we need to make sure that we're personalising and tailoring the right channel to fit with people's needs and preferences. And as a community, I do believe that we need to do more to address health inequalities. We know that stroke is more prevalent amongst BAME communities and socioeconomically deprived communities, and those same communities are also adversely affected by COVID-19. And I think as a community, we need to understand more about what some of those barriers to access are, what are some of those health inequalities, and we need to challenge ourselves to do more to address and fill the gaps. We will be publishing the findings of our beneficiary survey in September. We'll be publishing a policy-led report with different versions for each of the 4 countries of the UK, and we'll be particularly prioritising those themes of mental health and rehabilitation, because they just do need to get heard by system decision makers and commissioners across the UK. And as Sue said, I think we need to challenge ourselves to make sure that we are evaluating the new innovations. We need to know what's working, what's not working, who it's working for, and how we can then mainstream and adapt our stroke pathways accordingly. So I'm now going to hand back to Derek for the questions and answers.
Thank you very much, Juliet, and thank you also to Pam and Sue. I've certainly learned things there and found that incredibly helpful. We've got loads of questions. We can't possibly deal with them in the 10 minutes we have left, but we will pledge to put an online answer to every single one of them as soon as we can. The one I do want to take, which I think is the biggie, if you like, is about future provision of services. And what we've been asked is, do we anticipate that stroke services and outpatient rehab in the future will return to full face-to-face therapy sessions, or will we be carrying out remote online therapy as a new adjunct to the previous service provision? Juliet, I might come to you first on the service user side, and then I'll come to Sue and Pam.
So I think that's a really important question, and one that we do need to answer. I mean, I suspect that we're going to be moving to more of a blended model. I think the reality is that social distancing is going to remain in place for some time, and that the risk of COVID is not just suddenly going to disappear from hospitals over the next few months. So I think it's going to be important that we look at a blended model, because we do have evidence that actually some stroke survivors can benefit from phone and video and other remote forms of therapy, but it doesn't do away with the need for face-to-face. So I think my response would be that we need to carefully assess people's needs. We need to understand people's preferences as well as their need, and then tailor the right form of therapy using the right channel to meet the needs of that individual.
Thanks so much, Juliet. Sue, remote and face-to-face going forward.
I agree with Juliet. I think there probably will be a blended model, and I think for dysphagia aspects, I do think remote working is going to be here to stay for some aspects of that, and it's already in the literature been evaluated well in some situations. But I think for dysphagia, one of the key things about whether we do or don't do remote working is to do a risk assessment and look at the risk versus benefits for each individual patient that you're going to be doing it with, and for what reason are you doing it. I think that there are issues around where is the person? Is the person in a care home where they're with a trained carer, or are they at home, and has that person had any training for signs to look out for dysphagia, and if you were doing an assessment, what to do if somebody choked. So I think who is with the person is a key question. I think what you're doing with the person in the remote session is important. Is it an initial assessment? Do we think that's too risky to do, or are there benefits if there are no other means of being able to do an assessment? Could you do a remote assessment via video? Certain things pose more risks than others. So things such as dietary upgrades pose more risks than if you were doing therapy remotely, perhaps, and we need to think about that. But I still don't think it's appropriate for everybody. I still think some face-to-face contacts will still be needed, and which is why I think it'll be a blended approach. I don't think there's a one-size-fits-all. I think on the patient's journey, sometimes remote might be useful, sometimes they're going to need a face-to-face appointment, and I think we need to take it on an individual case and look at why are we doing it. And remember, if we are going to do the blended approach, then we need to evaluate it properly and think about the patient experience as well of remote working, and see if that's what they want to do.
Thank you, Sue. Of course,
I'll add some comments. There's quite a lot of evidence that using computerized therapy for dysphagia and dysarthria is positive, and about 70% of the patients in the trials actually liked it and continued to use computerized therapy even when face-to-face speech therapy was stopped. Of course, a blended approach is important because computers can't completely replace the face-to-face conversation and encouragement that is required by many people. We have to remember that an awful lot of people may have difficulty accessing the technology that would support those approaches. So we don't want to make it more difficult and more inequitous to certain populations. So as Sue says, and as Juliet said, is yes, I think we should be doing more. Yes, it will help people to actually do better than just face-to-face on its own, because it allows more practice. But we have to be aware that there are some people where there might be an increased risk because of the approaches that we're taking, or some people will find it disadvantages them because they haven't got their access or the support locally. So I hope that we will go down the pathway where we use it more, but don't just abandon what has been tried and tested before. Thank you, Derek.
Thanks, Pam. And I would say in the RCSLT's own assessment of work needed going forward, telehealth and remote working, the positives and the challenges, is absolutely number one. Juliet, you made some very kind remarks around the challenges that speech therapy services and individual therapists face. I wonder if you have anything further to add about the use that can be made of service user voices and perspectives in, I guess, winning the argument. And linked to that, Sue, you mentioned service user choice. So anything further from colleagues on the service user perspective?
Yeah, so I mean, the reason why we are so obsessed about collecting robust data on the lived experience of stroke survivors and carers is not to in any way criticise the healthcare professionals who frankly are delivering a fantastic service, but it is to highlight to policymakers and system decision makers where there are gaps and where actually they need to prioritise investment and funding for the future. And, you know, I think it's fair to say that stroke rehabilitation has been the Cinderella part of the stroke pathway for some time. And that within stroke rehabilitation, I think we have evidence that speech and language therapy is not funded and invested into the level that it needs to be in the future. So we will be using the findings of our survey to put pressure on system decision makers across the UK and to engage in conversations with local commissioners about ensuring that there is appropriate local funding to implement the national clinical guidelines. And I suppose what I would say is that if in your local services you have really good evidence of unmet need, you've got a compelling case for investment, but it's not being heard by your local trust, then please do get in touch with your contact at the Stroke Association, because we're here to support you. And influencing the system is one of our big strategic priorities and something that we want to do more of, because the scale and impact of stroke is so huge that we all need to work collaboratively to get the messages heard. So that's how we'll be using that patient voice.
Thank you so much. I think that is going to have to be us for today, colleagues. We've pledged to end by 2 and we will do so. There's a little bit of housekeeping slides to come just before we end. I'm aware that we haven't had time to get into the massive issue of PPE, protective equipment, and infection control, but I know that Claire has posted in the chat the link to the latest RCSLT guidance, and rest assured, I mean, that's about my meetings this afternoon are around PPE ahead of any second wave. We just want to let you know about our next webinar, which is going to the other end of the life course on Monday, which is around telehealth again, but in the context of working with children. I would like to thank all of you. I can see the hundreds of participants who've joined us today. I'd also like to thank once again Juliet, Sue and Pam for all of their contributions. I'm not sure if there's any more housekeeping by way of conclusion. If not, then I will thank you all again for your time. We will post both the webinar itself and all of the Q&A as soon as possible, and have a good afternoon.